what we will be discussing today is what are social vulnerable groups, or what is social vulnerability according to definitions or according to frameworks, but more specifically on what are the advantages or barriers when we try to include those people or those target groups in research, and specifically in health research. So in research that might also impact their own health and public health in general. So I will also enlighten it with two examples from our own research, but I'm also very eager to learn from your experiences or questions or challenges that you might have been facing when you try to include those target groups in your research. And then we end with a few slides on a few tips on how you can include these target groups in your research, from recruitment to follow-up and the conclusion of your research or your trial. So we talked about those target groups, social vulnerable groups or social vulnerability, but what is that? And in order to talk about this target group, I think it's important to know that there's several views or several frameworks that try to scope or narrow down this broad group or term. But I think it's important, even though what definition you take or use, it is important to know that it is the component aspect. So social vulnerability is not only the social aspect, but as you can see, according to the definition of Ma et al., that's broader than that. So it's also your health that might be impacted, or nature or your environment that might impact you or might make you vulnerable, or it could be society. So it's not only the social aspect which plays a role, but it could also be another aspect. And so as you see these definitions, I'm not going to read them all out loud, but it refers to some sort of resilience that you have as a person in reaction or in interaction with society. And according to literature and to definitions that are already been pwned, we see that there's different indicators and themes that might make you more vulnerable when compared with other individuals. Examples are, and this list is certainly not exhaustive, but examples could be, of course, socio-economical status indicators such as age or sex or ethnicity, your education level, the income level, whether you are or not living in poverty, whether you have employment or not. Other aspects that are maybe a little bit less likely to be reported are the access to green areas or blue spaces like oceans or clean water and clear skies. The access to health services, whether you have access to education in your area, whether you are or whether you are not socially isolated, and whether you are living in a very densely populated area or a very polluted area might also impact your vulnerability. So I hope that by giving just these three, and these are a few examples of the different frameworks or definitions, because organizations like that to place or to make definitions. I think it's just important that if you want to target vulnerable groups, it is important to work inclusive and to not only think about definitions, because definitions often exclude certain groups or certain people. I specifically like the framework of Health Vermont, which is from the States, because they gave some sort of overview, and it is based in categories like from socioeconomical vulnerability indicators to something that says something about the population and something that says something about your environment. And so you see these numbers that are under each classification or under each category says something about a possible indicator for vulnerability. We already discussed poverty or unemployment. But for instance, if you see on the right-hand side, housing, transportation, etc., like if your household has no vehicle available, also that might make you vulnerable, as by which I try to say that if you have no transportation to your, if you have no transportation at all to get to a hospital or to get to some sort of local community center or to go to a school, that in se could also make you vulnerable. So it's broader than just looking at income, or whether people are highly educated, or whether they have health insurance or something like that. It's also your housing or your situation, or if you live in an area where there's a lot of health disasters, that also could make you a little bit more vulnerable when compared with individuals that live in a more stable environment. And also from the Indiana University, also from the States. I have no connections with the States, but it just turned out that these are two nice frameworks that have been published. But this also gives some sort of overview, what makes you socially vulnerable, but also what gives you a lesser status in according to the society, so minority status or minorities. Also, if you have some sort of composition in your household, let's say it's like a composed family consisting out of different genders and consisting out of different generations, that also might make you more vulnerable. And then, of course, they conclude with housing and transportation, just as the previous framework. So I tried not to bore you with frameworks, but I just wanted to mention these, as if you Google the term or if you PubMed the term social vulnerability, you might end up with a large forest of publications and definitions and views and frameworks, and it's very easy to lose track of them. I think it is just important, if you try to work with socially vulnerable target groups, that you try to be inclusive and not see it as an exclusive or exhaustive list of parameters. So another term or a synonym for societal vulnerability could be frailty as well, and by which frailty is most often referred to as the physical frailty, specifically in older adults, where you have the frailty, where you have physical parameters that might indicate that you are frailty or not. Societal frailty says something more than only the physical frailty. It goes beyond that, so it also says something about your society, your environment, the way that you can interact with society, that you even have interaction with society, that you're not living in isolation, and that it is cumulative. So it means that if you had one experience that might make you socially frail or socially vulnerable, the chances are higher that in the future you might have another experience like that. So in that being said, it means that social vulnerability might also be something that you inherit from previous generations, as if your predecessors or if your prior generation might have also been subject to or been socially frail or vulnerable, the chances are very likely that you might inherit it, and that you as a child or the next generation might also have or face frailty and vulnerability, and that it's very difficult to break out of that. It's also something gradual. So, as for example, poverty is something you might have lived in wealth, or it's very likely that you had a job and a good income, but due to some sort of experiences or aspects or things that just came across your path, your life path, it could be so that you would end up in vulnerability, in poverty, and then in isolation, and so forth. So it could be gradual as well. And people that face social frailty or social vulnerability, according to Vettenberg, which is a Dutch researcher, she researched a lot about vulnerability amongst youngsters in school. She also mentioned something that what makes you frail, or the idea, or the more primary aspect of frailty, is that you have fewer interaction with society, but also your interaction is less positive. So you get stigmatized, you get a guilt feeling if you live in a lesser nice house, or if you have fewer money than the average, then you get looked down upon. So it's the effects or the impact or the image that you have from a society is less positive, which also increases the likelihood of being drawn to having more experiences or more interaction with a society. If you have the feeling that you are looked down upon, you are not eager, or you are not welcomed to have more interaction with society. So it's more or less like a circle, a negative circle, and it's difficult to break out of that. Here's just another example of another view, another framework from Gamble et al. And here you see that it's not only health and it's not only your exposure or your interaction with society which makes you or could make you vulnerable, but also climate is something that might impact that. And there's a lot of studies now, especially with global warming, etc., and with changes in climate. There's a lot of studies that also say something about, hey, our climate also might impact your health, of course, but might also increase your vulnerability, especially in the States when you live in very dry areas or very wet areas or very hazardous areas with a lot of tornadoes, etc. That also in say might make you vulnerable. But enough said about definitions and frameworks. Um, why is it so important to have them involved in research then, you might think? Because there's a lot of people globally or worldwide that can be classified as socially vulnerable. Why is it important to target these groups or to have them included in health research in general? Well, we know that if you are more prone to vulnerability or if you are more socially vulnerable, we know that you are more exposed to having chronic stress, or the chances are more likely that you have been experienced more chronic stress when compared with other people your age or your group. And this chronic stress is often created or related to the exclusion that you might have experienced as you are part of a group that is looked down upon in society. You might have faced discrimination in terms of housing, in terms of education, in terms of health access. You might have felt stigma or stigmatized, and there's a lot of scarcity, especially in poverty, when there's not enough food or not enough access to health. And I think we all work in health, so we know that stress is often a negative or can have a negative effect or impact on health, specifically when it's chronic, when it stays for a longer period of time. And as due to this stress, we see that you are also more susceptible or prone to having a negative health behavior. So when you're experiencing more chronic stress, the chances are more likely that you take up unhealthy behaviors, such as a poorer diet, or you are more sedentary, you take up smoking or even drugs when you live in those areas where drugs is probably more often seen on a street or easier to get access to. And when you take up more unhealthy behaviors, it's like a negative circle. You end up in a lesser mental well-being, you get less sleep quality, you sleep less, you get insomnia, which also might increase your chances or likelihood to developing chronic diseases such as diabetes and cardiovascular disease, also cancer, which might increase, of course, also your mortality. So this poor physical and mental health, which you are prone to just by having the status of a social vulnerable person, might in time also increase your risk to develop frailty and might continue your negative circle that you have in terms of vulnerability. We also know that if you inherit vulnerability, so if it's socially inherited, if you get it from your predecessors and from previous generations, and we also know that if your environment is not stimulating you to take up healthy behaviors because they haven't learned so or they don't know what the importance is of healthy behavior, then we also know that health literacy is also lacking and even missing. So health literacy, that says something about how capable are you in getting access to healthcare, how capable are you in understanding and getting access to information about your own health or about health in general, how able are you to process information when a health provider talks to you and explains you something, that it is important to take up enough proteins and less sugar and that you have to cut up smoking, or that it is important to focus on better sleep behavior. So health literacy is something that often is also triggered in your social aspect. So let's say by your family and by your predecessors that might also give you this information, but also in schools. So if you live in lesser developed areas, especially abroad, where you don't have the chance to be educated regarding health, then the chances are very likely that your health literacy is very low. And now I'm talking about lesser developed areas, but even in Belgium, for some parts of the population, the health literacy is actually alarming. And there is a study from the government, from KCE, from 2019. Um, it's a report on health literacy levels in Belgium. It's very interesting, and if you have enough time in your busy schedule, it's worthwhile to read at least a summary of it. But here they say something about the health literacy level in Belgium, and it is problematic for 30 to 45% of the population, which is not half, but almost half, so one third to one half. So it's actually alarming, I would say. And it is actually our task as a health provider, of course, also educators and families and parents should also, of course, think about it, and schools as well. But it's also our task as a health provider to also work on health promotion and specifically prevention. Um, so what does that mean for Belgium? We talked about lesser developed areas, and if we talk about Africa, or if we talk about or Latin America, and then we say, oh yeah, maybe they have a lower health literacy, but it's also closer to our beds. It's also here in Belgium. They have less access. It translates in a lesser access to healthcare. So not all people go to a physician, know their way to the physician. Know their way into the health system if they have had symptoms for over months, maybe years, and they don't even realize that it might be something more serious, then they don't gain access or they don't search for health providers. And not only that, they also get discriminated against in healthcare system itself. So VAROS is a research institute from the Netherlands, and they had a publication. It's quite interesting. It's quite recent. It's from 2022. It's about the discrimination level in healthcare, and that is actually in the Netherlands, so it's not so far from our bed either. And they gave some examples on how people were discriminated against in healthcare institutions. So that could be that if you don't have enough money, then you don't get access. If you don't belong to some sort of certain group, then you don't get access to the highest experts in a certain field, etc. So it is not something that is only in the lesser developed areas worldwide, but it's also going on in Central Europe. For your information, I've placed all the references at the end, so the last slide contains a few references if you might want to check them out. So we talked about social vulnerability and health. So they're more prone to poorer health. And not only that, they're also susceptible or more prone to a lesser access to health or to being discriminated against. And that means that health programs or health interventions or even health information is not always accessible, is not always translatable, is not always low threshold, tailor-made for a group that has a lower health literacy. And we don't have to look too far, but if we look at guidelines that are published in Belgium, let's say Vlaams Instituut Gezond Leven, which is now under the term Gewoon Gezond Leven, they have a lot of information which is quite interesting regarding movement and regarding the guidelines regarding nutrition and healthy nutrition. Those are really nice instruments, but they don't always translate to a population that has a lower health literacy. So it is important for us as health providers to make that information a little bit more low threshold and a little bit more tailor-made. And that is why it is important to, before you target these groups, to detect their needs and their expectations. So you could approach them and you could reach out and ask them, what exactly do you need? And looking in their environment or in their situation, when you compare it to people who are less socially vulnerable, what might they need in order to increase their health? So then we think about two things, and that could be participation, but also equity matters. So in terms of participation, maybe you've heard already from the participation ladder. It's the model from Arnstein. It actually self-explanatory because it's the ladder, and it means that if you start at the lowest spot of the ladder, it means that you are less participative, and if you end up at the highest spot of the ladder, that means that you are the most participative in your society or in your organization or in your research. So I will give an example of that later. And then equity, that all comes down to how to make your program or your organization or your information or your um, program that you would like to disseminate, how to make that so equate or so accessible to a group that everybody can understand what is actually being explained or being presented there. And there you have several models. We have the 5 A's or the 8 B's. So it's just a way of how organizations frame their models. So I will also give an example of that. So as for participation, you can just Google the term, the participation ladder of Arnstein, and you'll find plenty of ample um, experiences and figures of the participation ladder. There's ample of research on how to increase participation of, let's say, family members in a nursing home, or participation of employees in a bigger organization, or the participation of citizens in a society, but also the participation of participants in your study could also be viewed upon by this framework. And so you see that there's different levels actually in this ladder, and you see it goes from manipulation, or something that you do as a researcher, let's say in an RCT, where you have the complete manipulation, or where you have where you allocate people to a certain group according to, of course, algorithms. But there you have manipulation, and the other aspect, or the other side of the spectrum, is then the total control is with the participant itself. So then we are more in the type of research that has the implementation, or civil research, where we have the participants of society that make up the research. So it's like a spectrum. You can see it from left to right, or right to left, or up, down, 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 bottom. And here in green, I just circulated a few words which might be interesting when you try to work with these target groups, as it is, of course, important to inform them. But when you do that, when you inform people about health or the research that they're involved in, it is not only important to inform them, but also to make the information that you provide low threshold. So I believe that if you have like a movement program, or a program regarding sleep, or a program regarding healthy nutrition, it is important to work with low threshold information, visible aspects. You can have more aspects in your education that are a little bit more fun to work with, like serious games or games, like group sessions where you have interaction. So you make it a little bit more low threshold. But for certain aspects in your research, let's say the informed consent or the protocol, which is, we can all agree, is quite dry information, it is quite challenging to make that low threshold. So as for these aspects, because also these participants need to sign your informed consent, it is important to have it translated, A, to their language, and B, to take enough time to bring over your information in such a way that it is understandable, relatable to the target group. So why not work out your informed consent in a dry version, which you also use for the ethical committee, but also for your ethical committee, also submit a version that you use while informing your target group. So that can be with extra information, that can be with examples, that can be with visuals, in order to make your session, or to make your informational session, a little bit more clear. As for the aspect 4, consultation, I think that that is also something that will come back in the examples that I will tell you about. So consultation, that has everything to do with how you consult, or how you ask your target group how your program or target or study could be improved or could be more tailor-made. So in this step, you actually approach them and ask them, what are your needs? What are your expectations? What do you think this program needs in order to make it more accessible to you? Or do you think this program is something you might follow? Why yes and why no? And then you can alter your program according to the consultation that you might have had. So this is actually more a co-creational step, which in participatory research is highly valued. I'm not so sure about fundamental research because there it's a little bit harder to also involve a consultation, but it is worthwhile to explore whether it is possible. So if you go for external funding, always make sure that if it is agreed upon by the financial organization, that you might also increase or involve co-creation or co-development or participatory research in your study. And then I also added partnership because that is one of the things that we often use, as in that we often see the participants themselves as experts in their own situations, and that we as the researcher are more or less the observers, and we also try to learn from them. So by giving them the expertise or by giving them the respect in their own situation as being the expert in their own situation, it helps to keep these people in your study, because we will talk about follow-up and adherence and compliance, and it's very easy to lose people from social vulnerable groups as they don't always see the benefit of participating in research. So by making them a partner, by giving them the right respect, and by giving them an actual place as an expert in the study, by involving them and also giving them maybe some tasks in your research, it helps them to keep them close and to give them some, well, not responsibility, but maybe some tasks or something that they can be proud of, and they feel more linked or associated with your research, and it helps to decrease the dropout. And then as for the equity aspect, so it's all linked to each other. I think you can use different frameworks. If you would just Google equity or models for equity, I think you can find a lot of alliterations there, but this is the most famous one, the 5 A's, and it all comes down to 5 words that start with an A. So your program or your study or your health information should be available, should be made available. Let's think about open access. It should be accessible. So that means that there is no thresholds. Let's say that if you make a program and you only give it in an online way, but you also try to involve people that are having difficulties finding internet, then it's not accessible. Or affordable. So if your program requires that people pay some money or that they have to go through different health providers, then it's not affordable. So make it low thresholds and even for free. The acceptability by a group, that has everything to do with, is the group ready to receive information from you as a researcher or as a health provider? But also, how about your information? Is it something that is that low threshold that it is readable, and so that the group can actually accept the information that you are giving? A good example there is, again, the ethical committee documents, the informed consent or the protocol. If you're having a hard time reading Dutch and you get an informed consent in Dutch, then it takes you a long time, over a lot of time, to read it and to keep your concentration there. But even if you have less health literacy, or even when you're illiterate and you're having a hard time reading in general, then it is very difficult to accept what is being given to you as information. And of course, also the appropriateness. Try to make sure that the things that you try to give to this target group, or you try to have changed in a target group in your study, is also appropriate. So therefore, it's important to also assess the needs of the target group that you are targeting. If you didn't do a needs assessment by means of a live assessment or by literature, then the chances are very likely that you try to change behavior that is maybe not necessary, or that is maybe not even appropriate to discuss this item or this behavior. So in order to make your information more appropriate, it's important to be linked with your target group and to know what they need in order to make your information more appropriate. So this is an English model. And for Dutch-speaking people here, of course, Vlaams Instituut Gezond Leven has also a very nice model with 8 B's. And there you see, based on the words, that it all comes down to the same thing. Make your program usable, so it's affordable, it's accessible, it's understandable, it's famous, you get access to it, it's reliable. If you need more information regarding that, I placed the references at the end of the presentation. But if you make a program, or if you want to develop a study or an interventional research, then it is important to just verify for yourself everything that we would like our participants to do. Is it according to these 5 A's or 8 B's, or the participation letter? Do we take this into account? Because as for a social vulnerable group, it is so important to keep these things in account in order to increase the amount of participants, but also to keep these participants in your study from beginning to the end. As for examples in own research, and probably you are already working with some socially vulnerable groups from young to old. As for our research, I've brought in here 2 examples. Our first study is the AHA study, which is an active and healthy aging for all program. It's a study that we started at the Odyssey University of Applied Sciences at 2019. And it's actually a healthy lifestyle program, which covers an integral aspect of lifestyle. So more than just movement and nutrition, but also stress and sleep and meaningful activities, how to have social engagement and motivational aspects in order to keep up your healthy behaviors. But what was so specifically here, we tried to target the social vulnerable older adults. So those were older adults that were having less access to health, that were illiterate or had a low health literacy, that were living in poverty, people that were immigrants, people who didn't understand Dutch. So it was a very broad group. And we worked together with a lot of community centers, organizations for home nursing or home care, health community centers, local bodies and organizations. And we first conducted a needs assessment with the target group. What do you, as a socially vulnerable older adult, need in order to take up more healthy lifestyle behaviors? And then it became quite clear that they didn't understand what is the term healthy behaviors. What do you mean by that? So then it became clear for us that we need to go a little step further into the needs assessment. Like, what is health to you? What does that mean to you? What makes you age in a healthy way? What do you need in order to stay healthy? And then for us as a researcher, it was quite interesting to know that, as for us, specifically for me, I was focused on physical activity and sedentary behavior and sleep. And then it became quite clear that for them, it is so much broader than this. So they also had meaningful activities. They had social engagement was important to them. A close contact with their relatives, but also with friends. So it helped us shape a program, and we did that in co-creation with the older adults. So by doing that, we involved the older adults as experts in aging, because myself, I try to consider myself not to be too old, but I'm not an expert in aging because I'm quite young when compared to these older adults. So they're actually the experts in aging, and we are the experts in the research that we conduct regarding aging. But we try to implement and to involve the expertise they have on aging. And we did develop it, we did implement it, and we evaluated it. But during each step, we tried to implement and involve and welcome the expertise from all the older adults, as it was a co-creative participatory research. Also, in terms of dissemination, even now we try to have these older adults involved when we organize sessions, or when we have something on social media. And they're very happy to do that because they were so involved in the program, and they feel that they're responsible to take up these tasks as well. Another example is in people with early onset dementia or young onset dementia. So that means it's dementia that kicks in at an earlier age prior to 65 years. In Flanders, we have 0.07% of the Flemish population that have, or that is estimated to have the diagnosis, but only 1,800 people have had the formal diagnosis. So it's a very scarce group. It's a rare disease, but it has a high impact on quality of life. So it's a quite social vulnerable group as they are younger. And when they get the diagnosis, they are often cut off from societal living. So that means that if you get the diagnosis of early onset dementia or young dementia, it means that you are often have to stop working, that you lose your role as a spouse or even as a parent because you get institutionalized, that you have to stop driving your car because you lose your license, that you are no longer able to live alone just from one day until the next. So it's quite difficult for these people to stay in contact and to stay in relation with society. So they easily get socially vulnerable. So it is also quite hard to find them and to recruit them. So what we do, we worked with local bodies like daycare centers, with nursing homes, with social groups, lotgenotengroepen, and with family groups as well, with voluntary groups, with community centers, and we try to do some outreach via in organizations and social media. But what we also did was a social needs assessment. So we asked the people with early onset dementia themselves, what do they still need, and what are their social and cognitive capabilities at that point, because you have a lot of cognitive decline and it goes faster when you have early onset dementia when compared to late onset dementia. So we asked them what they need, and specifically in terms of anxiety or stress or sleep problems that they might face. And we did not only do a needs assessment with the people with cognitive decline, but also with their spouse or children or a caregiver, formal and informal. And based on these experiences, based on these needs and expectations, we developed a 6-week program, which was tailor-made for the target group. But you hear me coming. It's a group with cognitive decline. So if you work with dementia or people with a cognitive decline or with a mental disability, it is so important to also involve them. So it doesn't mean that if they have a cognitive decline that you should only make programs for a group and not involve them. At the Alzheimer Association, they have this saying, and they say nothing for us without us. And it is totally true, because you have to implement their meaning, you have to implement their needs, you have to involve them in some way. So you could do that by checking in, especially with the people themselves, but also with their environment, their caregivers, formal and both informal. And so make the sessions low thresholds in order to have it more fun, in order to have participation, to make sessions short, to keep their attention span high, and also to implement it with some sort of exercises, so to motivate them to come back to your next session. So in order to decrease the dropout and increase your adherence, it is important to make sure that you have the same phase that comes to the social setting. So that means that there is recognizability in the trainer that gives the program or that gives the interventional research, that it is the same person that they see week after week, and that it's the same person that does the measurement, because it's some sort of a trust that trust a relationship that you build upon. So in order to increase your adherence, it is important to also take that into account. I'm also looking at the time, because we are quite limited as for today, but a few more words on how to involve then people from beginning to the end, so from recruitment to follow up. And as for recruitment, people who have already worked with these target groups, it can be quite challenging, but it is very fulfilling as well. Because once you get the chance to meet and to bond with people from specific target groups, you build up on some sort of relationship, and once you get to convince them and you get to motivate these people to stay in your trial, they are so motivated, and afterwards they're so interested in also hearing the results, but also sharing the results with their own peers. So it is quite fulfilling as well, despite the challenges or despite the efforts. So what is important in recruitment is your outreach. Don't expect people to just apply for your research, as they often are illiterate or having a hard time reading, or it is not tailor-made for them, or they feel they would be left out or discriminated against. So as a researcher, it is important to come out of our iron tower and to just go to the field and talk to different organizations, talk to local bodies, to community centers, to general physicians' offices, to pharmacists, to local shops, to libraries, to et cetera, to have an outreach. And that means it takes a lot of time. It's quite time investment. Time consuming, but it is worth the wait, because if you have a personal connection, or if you reach out and they always see your face coming back into the center again, it is easier for them to also talk to you. So do not expect that these people will just sign in for your research in mass of numbers or in big numbers, but it should be the other way around. And a neighborhood analysis is one way to do that, in order to keep your environment clear, or to have some sort of look on your environment, like who's involved and who's living in that or that area, what organizations are active in the area I'm trying to approach. Is there informal and formal care I can try to include in my research? And so there's a few aspects in participatory research that might be interesting for you if that is the case. Um, Buurtscan is an example of an exercise there. So it's, the word is actually self-explanatory. So it's a scan of the neighborhood. So here you see on the right-hand side, it's participatory research in Brussels area, where you have like a map of the area, and there you can just see, okay, where are organizations I can target, where are bodies of formal organizations regarding health or welfare located, where are public organizations settled, let's say a library or a cultural center or a community center, where I can just go to and have my explanation done, or together with a colleague, we go to some sort of public organization, and we have them ask, can we please give some information regarding our research? Can we get some people together? Can we join during the coffee moments or during the lunch moment to just explain to people what we are doing and what we are looking for? So if you're interested in that, there's quite a lot of examples in Flemish literature, but also in international literature. So Buurtscan is one, Doeboek and Vinsinia is also one. We also have vitalcities.be is also a website from the Hogeschool Ho West, I think, if I'm not mistaken. And also Odyssey has a booklet on ResoKit, which is something about Buurtscan also in the Brussels area. So it is important, if you try to target your environment, specifically if you want to specifically target a certain group, it is important for you to just check and identify the bodies or the organizations or the institutions that those people might go to often. So that could be a school, of course, if you target younger groups, or a daycare center. But also if you have like, if you try to involve people with from different ethnicities or from different religion, it is also important to also approach places of workshops or churches or local communities from that group specifically. So do not expect that only a physician will guide them to you. It is also important for you as a researcher to reach out. And I already mentioned it, it's quite time consuming. So if you would write for a financial body, you would say, I would like to have a research proposal written down. It is important to keep track of your time planning and to make sure that you have enough time for your recruitment. Don't take it for granted, because the investment that you make in your recruitment will actually serve you right at the end of your program in terms of adherence and dropout. As for involvement, I think it's important to have them as an expert, to include them as an expert, and to also involve them in different steps in your research. If you have a certain research question which you cannot alter, or a certain program that you cannot alter, it is always important to just ask them, this is the program that we like to do. What do you think could make it more feasible according to you? And maybe some things you can take into account. So I know very well that as a researcher, you don't always have the opportunity to change everything in your research question, but maybe it is an idea to ask them also about aspects besides your research. How can I make it more feasible for you that you could access the sessions? How can I make it more feasible to you that you maintain or that you keep up your exercises at home? How can I make it more easy for you to read and understand my information, for example? So if you cannot change your program or your study or your research question, that is fine. There's different steps in the ladder of participation. But besides information and just having them as a participant, it is important to also include their expertise. And you could easily, that's something that we often do, you could easily have them also implement or have them involved at a later stage in your research in terms of valorization and dissemination, to have them also help in some sort of sessions that you use to have other people involved and have them talk about their experience on the research or the participation they had in your research, because they often like to talk about it after they have done the research themselves. So I think check-in is important, like a needs assessment, check in with their feelings. How do you feel about the research? Even if you notice that during the research they try to drop out, try to keep the link close. So keep the connection warm and call them, check in with them live, have extra time, foresee extra time after your session to just talk to them. What did you think about it? How are you doing? How are you keeping up with the exercises? What are challenges to you? Pay them a visit. I know it's quite time consuming. We had this study with these older adults, and during COVID, we visited all of these older adults just to make sure that they were covered in all their needs in order to keep up their health behavior. It's quite time consuming. So if you would like to do that, make sure in your time planning that you also take this into account, because it's easily forgotten otherwise. So involve your environment and your neighborhood, not only the target group itself, but also think about what other organizations are also targeting these groups and working together with these groups. So it could be that in library, there's lessons for, let's say, digital literacy, working with a computer. Maybe it's easy there to just go there and then say, hey, is it possible for me to just talk to your target group and just explain them what in research I'm doing? And maybe by doing that, you could also have a lead of 1, 2, maybe 3 older adults that might be interested in your research. As for motivation, I think I can be quite short, as we are all health providers. And I think in some way we had some information about motivation and the self-determination theory. The most famous framework there is that from Deci and Ryan, which says something about the frame or the aspect or the spectrum of motivation, that it goes from being amotivated to being intrinsically motivated. And it is often so that socially vulnerable groups, when they get the advice from a doctor to, let's say, for instance, stop smoking, then the chances are very likely that they are motivated because it was someone else who told them, and they don't really have the motivation themselves to stop smoking. So in order to shift in the spectrum, to change your motivation throughout the spectrum, it is important for you to be beside the line or to cheer them during the aspect of being from motivated to motivated. And you could do that, or you could help people being motivated by asking them what they need. Specifically, also in an amotivated individual, it is interesting to learn from them. What did the doctor say? How do you feel about it? What do you need? I hear you don't want to change your behavior. Why not? Did you already tried it? Did you have poor experiences with it? How can I help? So it is important to have some approach there, and also keep in the back of your head that it can be quite that it takes some time in order to change your behavior. So motivation is something that you will check every time when you see these people. Check in with them. How's your motivation? Do you still are you still eager to be part of the program? What do you need from me as a researcher to keep you motivated? How can I help keeping your motivation up in order to keep your dropout low, and in order to keep your follow-up high, so the adherence to your program, you can increase it by also checking in and to help them adhere to the program and the exercises that you want your your participant to do at home or during the sessions. So it is important to ask for reasons. Even when they have dropped out, try to contact them and try not to lose touch, because the reasons that person A has could help you for person B, C, and Z to keep them in your program. So it is very likely that you have dropout, but learn from the dropout that you might have. And so by asking for reasons, you could prevent and anticipate for possible future dropout in your program. So I tried in this short time, and I see that it's almost time. There's a very unreadable slide. I'm sorry for that with all the references. But I'm thinking that you will get in the slides, I guess, so you can read it at your own pace. But if there's any questions for the meantime, I'm very happy to answer them. If you still would have questions in the future stage, you're very welcome to send me a mail or drop me a message. And then I leave the floor to you, Eva, to see if there's any questions there.
Yes, so indeed, if anyone has a question, you can just turn on your camera and microphone and ask it, or use the chat function. I will wait maybe a little to see if someone pops up here. And otherwise, I have a question.
Great.
Okay, I think I go ahead with my question and maybe others will follow. So if I understood it well, in your research, you are, or in specifically this type of research, you are specifically targeting a vulnerable target group for a trial that you're running, or something like that. I was wondering whether that's the ideal situation, or would it even be better to have like very large clinical trials where you have all layers of the population involved, which makes it probably more challenging. But yeah, I would like to have your view on that, maybe.
Yes, it's a very good question, Eva. I think indeed, in terms of bigger trials and in order to make it cost effective, I think it's important to include all layers of society. I think that is also something that financial bodies also ask, like, what is the impact of your research? And in your generalizability, you can only say something about that specific target group. Well, it limits your validity, of course. You can only say something about that target group. So if the financial body demands that you cover a broad range of participants, then of course, yeah, I think it's necessary to include more layers. But also there, I think it's interesting to have a needs assessment with your target group in different layers. And if you approach or if you target and develop or make your program or study that low threshold, then it is also accessible to a group that has a higher literacy. So I think if you don't want to be exclusive and you don't want to exclude people, I think you'll have to start with the lowest level. But that also means that you have a lot of work in altering the study or the documents that you would like to give, or the program that you would like to conduct. So I think it all depends on your research question. Here, the scope was, of course, vulnerable target group. So if you have specific research questions regarding that specific group, it's important to only focus on that group. But it also says something about your generalizability. So I cannot say something about, hey, what we saw in our research also applies to very healthy, motivated older adults with good health literacy. So it limits your findings, but on the other hand, yeah, it also depends on the scope of your research.
Mm-hmm. Okay, thank you. I think there's a question with Eva Rose, or I don't know who has the question, but there are a lot of people, or some people together in one room. So we cannot hear you. Technology.
Mm.
It's okay.
There's an echo.
Yeah, it's
Oh.
okay.
Yeah,
Is
now
it
we
good
hear
now?
you. Yeah.
Okay.
Thanks, Julie, for the masterclass. I have a question, and it's maybe a bit related to the previous one. When selecting a group which is socially vulnerable, is it relevant their own perception on vulnerability? Because we saw some some of the objective reasons why you think someone is vulnerable, but their own perception, and how do you apply that or take into account?
Yeah, it's very good that you say that, because it's true. It's actually not something that you can objectively measure. You can, there is criteria for it, and you can say that might make one socially vulnerable, but it doesn't necessarily mean that you identify with a social vulnerability as such. So to add an example, I was presenting our research it was in a conference, and at the end of the presentation, there was a professor who asked as a question our research team in general, and they said, hey, looking at the people that are on the pictures there, they don't look so socially vulnerable to me. And then it opened our eyes, as in, yeah, what is social vulnerability to you? Because it doesn't mean that someone is dressed properly and has glasses on or can read, that it doesn't necessarily mean that they are not socially isolated, maybe, or that they have other aspects that might make them feel social vulnerability. So it can work in two ways. It can be that somebody doesn't have the appearance of being social vulnerable, but they can be. And on the other way around, it can be that we might think or identify someone as being social vulnerable, but they don't feel that they are. So let's say a good example there is poverty. I think if somebody is living in poverty, maybe we living not in poverty might suspect and say, oh wow, they're so socially vulnerable, let's target them. But for the same reason, it could be that they say, yeah, I feel happy and I have access to healthcare and I don't feel social vulnerable at all because I have enough social contacts and I have society, I have interaction with society. I don't feel unhappy. So I think it's important to also take into account their perspective by a needs assessment or by just an intake or something like that. So subjective findings are very easily ignored upon, I think, in this type of target group. So it's important to take them into account. Yeah, it's a good question.
Okay, thanks. That was it.
It was not a solution, I think, to your question, but
No.
I think it should be taken into account.
Thanks.
I have maybe a follow-up question on this discussion. If you say that indeed the perception of a person can be different, then I think that it can also be something that they perceive as something negative. So my question is, do you like put it up front that you're specifically targeting these vulnerable target groups, or is this kind of concealed for applicants to participate, or how do you cope with that?
Yeah, that's a good thing, and it's also something we try to be subtle in it. So for some groups, of course, for early onset dementia, it's just the diagnosis that they get, which might make them socially vulnerable. So there it's not concealed. But as for the older adults, we target them as older adults and not as older adults that are socially vulnerable, because that also might bring up stigma. So what we do is during the intake and during a lot of focus groups, we try to ask them about, let's say, social isolation, that it's one topic in one of the sessions, and then we ask them just as an open question. So in an intake, we do have some questions that help us understand what is the backside situation of that person, and also we have during an intake we do some surveys, which are anonymous, of course, just to have an indication of someone's level, educational level, income level, social engagement, etc., health literacy. So those are things we try to assess via means of questionnaires. But the approach is not like, hey, we're doing a research with socially vulnerable older adults, and I think you are one. So we don't do that specifically. But I think sometimes it is being done like that in clinical trials, because then you are doing research in a very sterile way sometimes. And I understand as a researcher, you cannot always alter your research questions, specifically if you're doing fundamental research. So there it's necessary that you keep track on specific target group. But as for us, we do practical participatory research. I think you can keep it broader in order to decrease the stigma and also to decrease the chronic stress that they are already susceptible to. Yeah.
So I would like to thank you on behalf of the research group for this lecture, and yeah, we will keep in touch later for the future and hope to collaborate on this topic also.
Sure, gladly. It was my pleasure.
Good.
And hope you have a nice rest of your day.
Yeah, thank you very much. And thank you everyone for attending also, and have a nice evening.
Bye.
Bye-bye.